especially in the regime of chemotherapy-induced thrombocytopenia. So what are the current protocol for its use and when to use, and what are its common side effects? So we'll just have a discussion, and I'll only want the inputs from our esteemed panelists regarding this. So I'll come to Dr. Anuj only. So Dr. Anuj, so is it a common problem, chemotherapy-induced thrombocytopenia in your clinical practice? So almost what percentage of patients do you think have this problem in your clinical practice?
Yes, this chemotherapy-induced thrombocytopenia we very routinely encounter, especially it is related to some of the chemotherapy regimes, like if we are using a carboplatin-based regime after prolonged therapy of after 5 to 6 cycle, or if we are giving in combination with gemcitabine or gemcitabine alone. These are some of the drug which causes thrombocytopenia, and especially when we uses this agents in second and third line, this combo type CIT is common, I think, in can say in around 30 to 33% of the patients.
So that's correct. So something we see around 10 to 20% patients have this problem. And in later lines, as we go on with the treatment in second line and third line, these patients may have a chance of bleeding. And sometimes in few cancers, bleeding may exceed up to 20% group. So Dr. Vipnesh, so what do you think? It is the nadir platelet count or the persistently low platelet count, which is important for us to manage a case of chemotherapy-induced thrombocytopenia? What do you look?
I think persistently low is more dangerous, and which hinders the effective delivery of chemotherapy, because sometimes the patient will have nadir and sometimes we reduce the dose, but it is not the mechanism is not very clear that it happens every time or it may not happen every time. So sometimes when we skip the dose and delay the dose, then it will recover, and other times it will not happen. But the persistently low platelet counts, it will delay the chemotherapy in every cycle, and that requires dose reduction or addition of other agents for the same.
So correct, I think so. It's basically the nadir is the lowest platelet which we are getting, and it might get improved within a 2 to 3 day span. So it is not much concern if it is not going below 20,000 in the patients. But for persistent platelet, obvious chemotherapy cycles are delayed in most of these cases. So I come to the hematologist, especially Dr. Sumit. So just a clinical normal thrombocytopenia, what are the workup you will going to do with these kinds of patients? So
it depends what the clinical scenario is. The patient will receive chemotherapy. In all likelihood, it is chemotherapy-induced thrombocytopenia. For patients' baseline thrombocytopenia, we always do viral markers and a peripheral smear. Peripheral smear to look for any giant platelets, large platelets, to rule out pseudothrombocytopenia, and viral markers to look for any reversible, correctable causes. If there is acute history of fever, there is sense in doing dengue and malaria workup. Otherwise, not much. Bone marrow examination is not routinely done if the answer is you get from the routine blood test. Otherwise, it is not a standard of care.
So correctly. So I think so only in the cases we are suspecting MDS-like picture, we are going for the bone marrow. Otherwise, the routine viral markers testing and the peripheral smear is the most important thing, apart from ruling out the infectious causes for these group of patients. So regarding I think so Dr. Marley might take this. So is there any difference between the thrombopoietin agonists which are available, romiplostim and eltrombopag, already discussed in the last slide?
Of course, yes. If you look from the mechanism of action point of view, so the site of action is different. This romiplostim is basically a thrombopoietic mimetic. It acts at the same point where thrombopoietin is acting, whereas the eltrombopag attaches to the membrane. So it attaches to a different point than the thrombopoietin. Then if we look at the clinical point of view, the route of administration is different. So eltrombopag is oral, the half-life is less, 6 hours around, whereas romiplostim is subcutaneous, it's given only weekly. So it is more beneficial, it is sometimes more convenient for the patient. Then another is the interactions of eltrombopag administration are more compared to romiplostim. It is a chelator. So we have to be very careful while using some cations along with it. Which is not the case with romiplostim.
Yeah, so that's important, and so we can also change if a patient progresses on one, we can go for the another one, and they have a lot of different actions. Might be some side effects profiles are higher with eltrombopag as compared to romiplostim in this group of patients. So this is how romiplostim acts on the thrombopoietin receptor, and down the JAK-STAT pathway it affects, and along with the RAS-RAF pathway, they find to decreasing the production. So Dr. Varanasi, so how often do you use either of in your clinical practice? I can say both chemotherapy induced in solid tumors, also in hematological malignancies.
So it's like case to case based decision, because there have been signals or concerns about the development of second malignancies, especially when we have used this in hematological malignancies. So across the hemato-oncology community, it is with a pinch of salt that we use either of these agents. But definitely in situations where you have delayed engraftment, or when we have to maintain the dose intensity for a curative intent treatments, like say carboplatin with concurrent chemoradiation, like say an esophagus with NACTRT. So these are certain indications where just to deliver the chemotherapy with appropriate dose intensity, I would err on using romiplastin. But again, how a particular patient responds to these drugs and how long will they respond to these drugs is something which is beyond that you can actually expect. Because as you know that there is some immunogenic potential for these drugs, especially for romiplastin, and the response need not always be sustained. So you don't expect the same response every time you give it. And that is the reason why we keep increasing the dose also. So my experience is limited to very few selected patients.
So what is the most common indication are you using? Means you have
In solid tumor chemotherapy, where there is an absolute indication, or where we know that compromising with the dose intensity would definitely influence the curative outcomes.
Okay. In hematological malignancies, why this drug is not used? Any idea?
So as I told you that, most of the times in hematological malignancies, the data is because of the paucity of data. And second thing is, most of the in hematological malignancies, we are actually looking at the marrow which is involved. So probably if the marrow is cleared of the disease, then you might not actually need this. So if you want to use it like in order to reduce the morbidity, perhaps yes, like what we do for delayed engraftment syndromes, or like post-transplant settings where you need to tide over that period, then yes. But again, long-term signals are like not so great in hematological malignancies.
Surely, no, basically in the hematological malignancies, the poor bone marrow reserve, I think so. And also the thrombopoietin receptor is also downregulated in that. So this drug is not going to act in that condition. Anything, sir?
Just to add what Dr. Avinash
Yes.
said, so the CME receptor or the TPO receptor
Yes,
is
yes.
also present on the leukemic stem cells.
Hmm.
So when the disease is not in remission, like an AML patient who's on induction, there is no sense of using romiplastin, because if your disease is not into remission, then there is no sense of giving more and more growth factors. And there is a possibility of malignancies or pushing the stem cell growth from the leukemic cell side, which will be a bad process in the bargain. Places where in hemat where I've used it in some settings is in the post-transplant, as Dr. Avinash was alluding to, especially when they have poor count recovery or poor graft function, like in haplotransplant settings, or occasionally in autologous transplant setting patients where the platelets are not recovering, but the neutrophil counts have recovered. Occasionally in patients of myelofibrosis, where they have persistently low platelet, especially when they're on ruxolitinib. And this is apart from their use in the low risk MDS and aplastic anemia patients.
Yeah, that's correct. So that's the use in there. So Dr. Vipanesh, I'll get back to you. So are you using it in all the settings or only in palliative setting, or in neoadjuvant or adjuvant setting also you're using this drug in your practice?
I'm not very much believe in the current data for this drug. So usually in the palliative setting, I would like to reduce the dose or to increase the frequency of administration. In the adjuvant setting, whenever it is like I said, the thrombocytopenia is persistent. In those setting, when because of thrombocytopenia, when the dose is getting delayed, only in those cases I'm preferring it. In the neoadjuvant and adjuvant setting, in palliative setting, better to wait, reduce the dose, that will be better.
So that's true. Basically, there are few data also earlier romiplastin if given in the earlier settings, neoadjuvant or adjuvant, it has a detrimental to the survival benefit. So mostly still we are not using so frequently. And in the palliative, if we have to give some chemotherapy to the patient and the platelets in the range of 50-60,000. So that's the best place, I think. So we are using this drug. I'll come back to Dr. Sumit only. So myeloablative versus non-myeloablative. So you're doing therapy. So in that case, do you think we are giving TPO mimetic agent?
So it depends what myeloablative regimen you're using and depends what disease you're referring to. If you're referring to 3+7, which is myeloablative in induction, then it is not, because the bone marrow, the disease is not in remission and the bone marrow is involved by disease. We're giving
something like paclitaxel with TIP regimen in germ cell tumor, which causes grade 4 thrombocytopenia in majority of patients. Therein, yes, because you want to maintain the dose intensity at the cost of bringing the disease under control. So myeloablative, yes, but depends upon the disease and the context setting.
That's true. So that's how we are doing that. So regarding that timing of romiplastin, I'll not go in that because Dr. Amit has just discussed. So this was a chart he has said that the weekly dose of romiplastin as compared to the intracyclic dose. So which is you think to be better? Dr. Anuj, can you take this? So whether the starting of the therapy, day 1, day 8, or in between the therapy, you're going to prefer this therapy?
I think this trial was conducted very well. I have gone through the trial, and it has compared both giving intracycle and along with the chemotherapy, and it has clearly shown that if we if you give intracycle, then it is doing better. But we are not for giving it routinely. We are giving on based on the demand. So because there is not clear indication, but in this trial it was shown that intracycle is slightly better.
Yeah, so truly, so we are just giving on demand these patients treatment. So, and that's also not on a routine basis. So it might happen. But according to the trial, they have shown that weekly dosing is slightly better than as compared to those of the intracycle dose in these patients. Yes.
So as Anuj said, yes, this trial did show weekly dosing is better. But when you see, look at the graphs, the black curve is 150 and 200 in between, and the blue curve is above 100. So it depends what the oncologist or the treating physician is comfortable with.
Yes.
I or my oncologist will be comfortable 1.1 lakh platelet count as far as it is able to deliver the chemotherapy. In comparison, 1.6 lakh, it is just a matter of semantics.
That's true. So mostly in our clinical practice, we are always following that. If the patient platelet drops in between, we are giving that before just the next cycle to have that. So, Dr. Malini, can you take this? So, in which condition are you think you're going to avoid this drug?
So as has been discussed before only, suppose a patient is of acute leukemia given 3+7 induction regimen, we don't know the patient is in remission or not, the platelet counts are not improving. In such case, we should not use romiplastin upfront as for improving the platelet count, because we don't know whether blasts are there or not, and it may increase the blast also. And there are like very less than 1% case reports are there where romiplastin can cause some reversible bone marrow fibrosis also. So that also should be considered in mind before using it.
That's true. So basically, it's the poor bone marrow reserve patient, any patient who have received pelvic irradiations. These are the patient one have, or the patient who have received earlier very myelosuppressive treatment like temozolomide. In this group of patients, this drug is not found to be functional, as discussed earlier. So I'll skip this. This has already been discussed. So might be Dr. Avinash. Sir. So the dose of his starting romiplastin. So it's have given a dose range of 1 to 10 microgram per kg weekly. So what is your preferable dose? Or it's a 250 microgram while you start with that same?
So I've been comfortable with 5 microgram per kilo to begin with, and then titrate it according to the platelet count. I'm not sure because I don't treat ITP. So in chemotherapy induced thrombocytopenia, beginning was with 5 mic per kg.
Dr. Sumit, how do you start with romiplastin?
Keep it simple. Use the whole one vial. We are Indians. We will use whatever we get. If the patient is very thin built, less than say 40 kgs, then there is also a new a reduced vial of 125 micrograms nowadays, which can use that also. Otherwise, we typically, in my practice, I use the one blanket vial of 250 microgram, which for a 60 kg patient comes to approximately 4 microgram per kg.
That's all. So that's the thing. So it might be the best dose. I haven't covered that, but it's something around 2.5 microgram per kg. It has said, and you can increase to 10 micrograms slowly if the patient is not responding to the. So the final questions to, I think, so I'll go with Dr. Vipinesh. So long-term use of romiplastin. So what are the side effects do you think it could have?
Yeah, as you told in the neoadjuvant and adjuvant setting, one of the concern is that increased risk of thrombotic events, and like for erythropoietin, these drugs have shown to be having adverse long-term effects and adverse long-term survival. So data is not very clear with respect to these drugs. So obviously these drugs and hematological patients, risk of clonal evolution and bone marrow fibrosis is also there. And sometimes rebound thrombocytopenia also seen.
So that's so true. So for romiplostim, there are few side effects, though it is better than eltrombopag, which has got hepatotoxicity, and the earlier recombinant thrombopoietin mimetics, which have got that I'll say antibody generation. So these are things which are not with this drug, and for timely completion of chemotherapy, this is one of the important molecule which we can use in our clinical practice. So one have to be keen when to start and when to give this drug. This is in our armamentarium, but to be judicially used in our cases, in these cases.